Welcome everybody to St Vincent's Research Week 2020 as we discuss the promise of cellular therapies for multiple sclerosis. This is a rapidly evolving field of medicine, and today we're discussing stem cell transplantation for MS. So as many of you will know, MS is a condition where the immune system attacks the myelin, cutting the signals on the nervous system and the brain, causing deterioration in functions such as mobility and speech. This condition affects 25,000 people in Australia, and it's very debilitating for some people. While there's no cure for MS, St Vincent's has been a pioneer in this area, particularly in the application of stem cell therapies that's been shown to reduce symptoms and slow the progression of the disease. And I did a story on it about 2 years ago, and I'm really looking forward to hearing the improvements and the deliberations since then. And St Vincent's and MS Research Australia have partnered on this particular research program to improve our understanding of the immune changes that occur in patients who receive these cell-based treatments. And the aim is that this work will be shared nationally and internationally to deliver better treatment outcomes for people living with MS. It's an intensive procedure with risks and other toxicities, and so we'll talk about some of that in this webinar this evening. The 5-year partnership between MS Research Australia and St Vincent's aims to clarify who responds best to treatment and ensure that more people with MS can access stem cell therapies under these trial conditions. The research program is led by Associate Professor John Moore and Dr. Jennifer Massey as part of the St Vincent's Centre for Excellence in Cellular Therapies. I'll just give you a brief bio. Associate Professor John Moore is a haematologist at St Vincent's and one of Australia's leading experts in this type of stem cell therapy, and he's been involved in these trials for the past 10 years. Dr. Jennifer Massey is a neurologist at St Vincent's, and she's been the recipient of an MS Research Australia postdoctorate scholarship. And her research is focused on examining the effects of these treatments on patients with MS. We'll hear from both our experts and how the St Vincent's team is embracing this highly translational multidisciplinary approach to improving outcomes for people living with MS. And importantly, we're joined by one of their patients, Justine Marenziak. Hope I got that right. She was diagnosed with an aggressive form of MS in 2015 and had a stem cell transplant in 2016 at St Vincent's. We'll hear all about that. And at the time of her transplant, she was supported by a wheelchair and had difficulties with speech and caring for herself. She's with us today. We're so pleased to have her looking so well. Thank you, Justine. Let's start though with John. You've had a long association with the field of stem cell transplantation for cancer and autoimmune diseases. Can you explain a little bit more about this and what exactly is a stem cell transplantation in the way you're discussing it and using it with these patients?
So stem cell transplant's been used for a long time for conditions such as lymphoma and myeloma, which are blood tumours. And in this procedure, we collect stem cells from the patient, we put them in a freezer, and then we give them chemotherapy, which kills off their blood tumour. And then those stem cells that are reinfused grow a new blood system. In multiple sclerosis and other autoimmune conditions, it was found that the similar procedure can actually help those patients with their condition. And we think it works on a slightly different way and that it grows a new immune system. And it was originally found out from animal models in the 60s and 70s, and then subsequently patients who were unlucky enough to have a blood condition plus multiple sclerosis or scleroderma noticed that with the stem cell transplant their conditions got better. And so from the mid-1990s, groups around the world have been using stem cell transplant for patients with these conditions who have failed other treatments. And what we've found more and more is that these treatments are working for particular subsets of patients.
And so the work that you do, though, is it still very much in the trial stage, or is this like would you say this is a sort of standard treatment, or it's still quite early in its in where it's up to for patients?
So for a condition called systemic sclerosis, it's now standard treatment, which is an autoimmune condition affecting the skin and the lungs. But for multiple sclerosis, there's only been one study that's compared stem cell transplant to other treatments. That study definitely showed that stem cell transplant was superior, but that's only one study. So most people around the world would like to see more research done in this before we take it further. Certainly at the moment we're still conducting it as a clinical trial because we feel patients need to be informed. And for us, we want to understand more about how it works, and that by doing it as a clinical trial, we can do the research that's required to try and work out how it works.
And we'll talk a bit more about that as we get into this webinar a little bit further. I might just move to Jennifer. So the application of stem cells for the treatment of MS was what you did your PhD on, and you also received a fellowship from MS Research Australia to understand the benefits and the risks of this treatment. Can you take us through which patients do you think benefit the most from stem cell therapy like this?
Yeah, so as you sort of highlighted in Justine's case, we've seen some really outstanding clinical responses in our MS patients undergoing stem cell transplantation. We know that stem cell transplantation works by knocking out the dysfunctional immune system that causes inflammation in the brain and the spine, and enables the regrowth or the resetting of a new immune system that appears to be more tolerant. And so patients who are most likely to benefit are those who have got very active or very inflammatory MS, typically earlier in the disease course, whereby stopping inflammation will not only prevent new relapses and the disability that comes with relapses, but will also enable neurological recovery from recent relapses and enable patients to be...
Can I just get you to clarify, when you say early on in the disease, is there generally a point where you'd say it's an ideal time to do this type of treatment in terms, or would you say there's a point where it's sort of too late as well? Do we know, are we able to be that definitive?
I think it's probably a spectrum, but certainly in people who have got relapsing MS without much in the way of fixed disability, are the patients who are most likely to benefit.
And so why doesn't this therapy work for all MS patients at any stage of their condition or their disease?
Yeah, I think that's a really important question. I think a lot of patients or people with MS have heard about other patients undergoing stem cell transplantation either here or overseas, and have seen these really impressive results and hope that this treatment may offer promise for them. But what we know is that as MS progresses from being active or relapsing into that progressive stage of disease where factors other than inflammation cause disability, the benefit tapers off. So whilst we see near complete suppression of relapses or new MRI lesions in people early in the disease course, people with more progressive MS really don't seem to garner any benefit from stem cell transplantation. And to that similar point, this is blood stem cells that we're talking about to try and rebuild a new immune system, which is very different to neural stem cells. So this treatment isn't designed to remyelinate or to fix damage that's already been done.
So you mentioned, and some people in the audience might have heard or seen stories about people going overseas for this procedure. We might just talk about what are the risks of the procedure generally, and then what are the risks of having this procedure outside a clinical trial setting?
Yeah, so obviously with any immunotherapy that we use in MS, there are risks associated, but this treatment is it's tough for patients to go through. So there's a risk of infection, there's risk of organ toxicity. Importantly, there's a risk or an effect on fertility. And most relevant is a risk of mortality, a risk of death. And so around the world, we think that risk varies between sort of 0.5 to 1%. We haven't had any deaths in our cohort or in our clinical trial at St Vincent's, but we do quote patients about a 0.3% mortality risk. And I think it's for those reasons that it is really vital that this treatment is performed or happens in a clinical trial setting and in a centre that's got a lot of experience in stem cell transplantation for MS. And in fact, all of the international data says that patient safety is most reflected in a transplant centre's experience. And so here we have now 10 years worth of experience in HSCT for MS, with very expert nurses, allied health staff to help us support patients throughout this journey.
Fantastic, that's great. So Justine is one of your patients and John's as well. Justine, can you tell us more about your journey with MS and stem cell therapy?
Yes, absolutely. Well, without sounding too over dramatic, if it wasn't for the transplant, I probably wouldn't be sitting here right now. I had my first symptoms in about October 2014. I just woke up one morning and I couldn't see out of one eye. And I guess things just spiraled out of control from there. I had lost my vision quite a few times. I had lost, half the feeling in half my body. I had started to have problems with my speech. Just all sorts of things were going wrong, and the doctors at first weren't quite sure what was happening. It was a very scary time, and I know people that experience those symptoms at first are not quite sure what's happening, and they do feel a little bit crazy, just as I did. I was diagnosed with multiple sclerosis, relapsing, remitting in August 2015, and of course, as most people would think in the first instance was, oh my goodness, I'm going to end up in a wheelchair. Luckily enough, we do have some disease-modifying therapies for MS, which are not a cure, obviously. And I did try a few of those, but unfortunately for me, they didn't work. And I did actually deteriorate quite quickly. So I had quite a good job before I got sick. I had a good career. I was healthy. I played sports. I was very outgoing. I was socialising a lot. I was 35 years old. I was in sort of the prime of my life. And then all of a sudden, it just sort of gradually decreased, and then it was a very quick downward spiral from there. And I was offered the opportunity to have the transplant, and I didn't even think twice about it. Prior to the transplant, you wouldn't believe it looking at me now, but I could not even walk 20 metres unassisted. I had to, just getting emotional talking about it. I had to have help with going to the bathroom, with showering, and the cognitive function was really quite bad. People would talk to me and I couldn't actually even understand what they were saying. My speech was totally gone, which was terrible for me, Sophie, because I love to talk. But it was just really bad, and I feel very, very fortunate and lucky that I was accepted into the trial by Dr. Moore. It basically saved my life.
So that's fantastic. Thank you so much for sharing that. Can you just take the audience through what was involved with the procedure? What was it like to go through?
Yeah, absolutely. Well, I do remember trying to sign the paperwork, and I had lost almost all function in my hands and obviously cognitively and my speech. But, I did manage to sign the paperwork, and I was so happy to be on my merry way for this transplant. Look, the first stages are you do get a little bit of chemotherapy that releases, I think, some of the stem cells from the bone marrow. There's some injections that you have to take when you're at home. Obviously, the chemotherapy, it's, it does make you a little bit ill, but there are so many drugs at the moment that can help you with that. So that was quite good. There's this wonderful process where you go in and they take the actual stem cells out of your body. So after they've been released through some injections that you've been taking, I'm sure I'm not explaining it very medically well here, but it's how I remember it in my mind. But they take the stem cells out, and fortunately, they did take enough out of my body, so that was wonderful. And then you do have to wait a little while, and you go into hospital. And I guess that's when it all sort of begins. You do start a very intense chemotherapy treatment that lasts about 6 days. It's 6 days in a row, and it lasts for quite a long time. I think it's more than a few hours a day. I'm pretty sure it's about 7 hours a day. I'm sure it is. And that's actually not too bad as well. And then a really great day comes where they come in and the doctors come in and they give you your stem cells back. And then you do obviously start to feel quite unwell. It is a difficult thing to go through. Would I do it again? Yes, I would. Absolutely. But yeah, it's a difficult time. You do need a lot of resilience. But I guess at the end of the day, you have to ask yourself, do you want to get better? Yes, you do. And that's all that I've ever wanted. And yeah, it for me, it's basically saved my life.
And there was quite a lot of rehab, though, wasn't there, to get you from that to where you are now?
Oh, absolutely. It's not a magical cure. You don't just sort of dance out of the hospital skipping, which would have been nice and very overdramatic, as I like to think I am sometimes. But no, I mean, I definitely did see improvement almost immediately. But there's I basically listened to everything the doctors told me, Dr. Massey, Dr. Moore, all the wonderful doctors, the nurses that have looked after me in the hospital. And I've just followed whatever they've said, exactly followed what they've said. It's very hard. You have very strict diet regimes that you have to follow. There's a lot of medication that you have to take. You have to make a lot of sacrifices, but at the end of the day, you have to ask yourself, what is most important to me? Do I want to get better? Yes. I was lucky enough to be involved in rehabilitation at Sacred Heart here at St Vincent's, and I was doing that twice a week. And it's almost been 4 years since my transplant, and I'm still doing that. Not at Sacred Heart because I'm not in the area anymore, but I do exercise physio 3 times a week, and I do physiotherapy once a week, including hydrotherapy. And I'm still following all the directions of my doctors. So I think that...
You sound like a very good patient as well.
I do. I just say, you tell me what to do and I'll do it. And I will do anything they say because the results are right in front of you here. But definitely, I think people need to understand that it's not a magic cure and there are things that you need to do in addition to that. So you need to follow through. You need to do your rehabilitation. You can't just do it for a week. You have to. It's been almost 4 years. I'm very conscious of what I eat. I try to follow different things that MS Australia have supplied me with, like meditation techniques and dietary requirements and all sorts of things. Anything that I can learn just to be better, yes, I would do that.
And just, you mentioned diet, and I was just interested, is that anything that a particular diet that MS Australia recommends?
Look, I think they recommend just a Mediterranean diet, just a healthy diet. Obviously, not too much processed food. I've obviously, I have a particular diet that I follow. I just find that my body will tell me if I've had too many Oreos, like I may have had this afternoon, but that's okay. Look, I think it's about being holistically healthy. And making sure that you're working at it every day. If I didn't do my rehab and followed what the doctors, asked me to do, then I would see quite a bit of a decline quite quickly. Yeah.
And it sounds like you work really hard at keeping healthy. So you're a great example to all patients out there. So I might just go back to John now, just to go back to some questions for you. Stem cell therapy, as you mentioned at the start, has been used with a number of diseases, but why do you think there's been a slower adoption of the treatment for patients, for people with MS in particular?
Well, I think there's a number of reasons. The first thing is that we're using chemotherapy in a non-malignant condition, so that's quite a big thing to do. You know, there's side effects, as Justine's outlined. You know, you're going to lose your hair temporarily. There's fertility issues because most of the patients are young females, so that's a massive issue that we'd like to address in the future. You know, we can cause infections and other problems for the patients, so that's one issue. I think the other issue is that multiple sclerosis in the last 10 years has had a large number of new drugs. So that means, and there's been a real focus now across to treating the immune system that's attacking the nerves in the brain and the spinal cord. So a lot of patients actually do well on those drugs. So what we're looking at are patients who have failed those drugs. So we're narrowing down the number of patients who might need it. As opposed to another condition, scleroderma or systemic sclerosis, there weren't treatment options. So I think that's probably the two biggest reasons why it's not necessarily taken off as much in multiple sclerosis.
So we've received some questions from patients and families who wanted to know about treatment overseas, which we mentioned earlier. You know, there are quite a lot of Australians who still go overseas to have stem cell therapy. What would you say to those people considering that, and what do they need to know?
I suppose the first thing I think is for them to have a good discussion with their neurologist or their GP just to talk about those options. Here we do offer it as a clinical trial, and we're offering it to people who we think would benefit the most. A lot of the people who go overseas may or may not have trialled other drugs first, and I think, you know, certainly some people can get really good long-term responses. So we've got Justine didn't, and so, you know, that's for her, the stem cell transplant was a good option. But there are people that respond well to Tysabri and Gilenya and other drugs. So those patients who go overseas often feel that stem cell transplant is the answer, and therefore they don't need to trial those drugs. And I think probably they need to maybe think about that. Of course, it's expensive to go overseas, and it's also they're going to be away from their family in a very stressful time in their life. So those things need to be considered. We would like to, you know, do as many patients as we can, but we've got limited resources. We're doing it in the public hospital, and we really have to hone down to the patients that we think will benefit the most. In the long term, there are 4 trials undergoing at the moment comparing stem cell transplant to Lemtrada and Tysabri and those sort of agents. So we'll get lots of answers over the next 4 years to really say, yes, this is who should have stem cell transplant, and we would hope then in the longer term that would be funded under Medicare, because currently it's not.
Oh, okay. At the moment, it's not funded by Medicare.
No, we're very lucky at St Vincent's that we do it as part of our budget, and New South Wales Health have helped us in that regard, but it's not formally funded under Medicare, so we do need that extra data for that to happen. And so really what in the Australian health system, we want to see several trials to show something of benefit before it's introduced into the health system. But you could argue that stem cell transplant will be cost effective in the long term, but we just need to see that data first.
And so with the data that you've amassed so far, we've seen Justine's improvements, but what have you seen? How would you categorise the data that you've received so far with the patients who've had this? What percentage or have a good outcome like we've seen today?
Yeah. So look, we would say that up to 80% of the patients, particularly the relapsing remitting group, have excellent outcomes where their disease is no longer progressing, that they're not getting new lesions on their MRI, and they don't need medication. But our average follow-up is only at about 4 years at the moment. So we published our data on the first 35 patients at 3 years, and we'd like to follow those patients for longer. There are not a lot of studies that have taken patients out to 10 years. So we're lucky this year that this is our 10-year anniversary of our first patient. But what we'd like to see is all 35 patients get to 10 years and really know where they're going to be in 10 years' time, because we just don't have that data at the moment.
So thanks, John. I'll just ask Jennifer. So MS Research Australia has made this amazing 5-year funding commitment to your research into stem cell therapy. And it's acknowledgement really of the importance and relevance of this line of research. What are the next steps for your research? What are you going to be doing?
Yeah, so I think that's a great opportunity to thank MS Research Australia. I think, you know, this commitment really shows their understanding of the needs of MS patients, you know, in this country. So I suppose our goal is to really expand our clinical and our laboratory research programs to improve not only the safety and efficacy of stem cell transplantation in the future, but also to enhance our understanding of the immunobiology. I think it's clear that treatment of MS is going to move away from long-term immunosuppression and ideally towards the immune reconstitution therapies. And so if we can understand how stem cell transplantation can induce, you know, disease remission for 6 or 7 or 8 years, we'll be better placed to develop therapies in the future that don't carry the same toxicities.
So in other words, you know, if you understand the process of what's actually going on, would the end goal to be to develop a treatment that would like mimic the effect of the stem cell therapy?
Yeah, that's spot on. And so if we can characterise the changes in the immune system, which is what we've been doing to date with our laboratory work, we will be able to target specific populations or cellular signalling that may replicate or, you know, mimic the stem cell transplantation, but without, you know, the effect on organ toxicity or the infection risk or effect on fertility.
And I mean, it's probably a long way off, but what's the time frame for that sort of approach? Like what's a reasonable time frame where, I mean, given you're only just getting to understand the process of how it all works, what do you think? Are we talking like 5, 10, or even further down the track?
I think, you know, I would be hopeful that every step of the way we will make small gains that will, you know, affect the way that we treat patients in the future. In terms of, you know, targeted cellular therapies, I would be hopeful that in the next 10 years we would have, you know, more to offer our patients. And so we're really trying to use this, you know, translational or, you know, bedside to bench research to detect, you know, real world outcomes from stem cell transplantation that we might be able to harness in the laboratory in the future.
And before I might move back to John in a sec, but I just had one more question for Jennifer. I was just interested in, you know, neurologists can cover all different types of conditions and illnesses. What particularly interested you about MS and then stem cells in particular? Yeah,
I think, you know, MS is a fascinating condition because there is still so much that we don't understand. It affects, you know, women, you know, as Justine said, at the, you know, the prime of your life. And so it's a disease that it's really essential that we as a nation, as a community are invested in trying to treat and trying to improve the outcomes of our patients. In terms of an interest in stem cell therapy, I think there's a lot of promise in this field. And you know, it's been a great team to be involved with and to work with, and so I'm very grateful for the experience and you know, the haematology department for taking on you know, a neurologist in this field, and to St Vincent's for kind of fostering this environment.
Oh, it's so fascinating. And John, I might just ask you a couple of more questions, and I might just start by asking you that same question. You know, there's lots of different areas that you have looked at in the past and focused on, but what's made you want to spend so much of your time and intellectual energy on MS and stem cells in particular?
I think since I was a junior doctor, I've been really interested in stem cell transplants. So that's like, you know, from about a year out of university, that's where I knew I was going to go. And then I ended up doing a PhD in this area, and so it sort of went from there. And multiple sclerosis is one of the most common sort of autoimmune conditions, and so and we've got so much to help these patients with who, you know, I think we keep saying at the prime of their life, and it really is predominantly young females, often with families who really don't want to get worse. You know, that if you say to them, we got a fairly good chance of keeping you stable at this level, they think that's great. You know, they're happy with that, right? What they don't want to do is deteriorate over time. And so that's very rewarding to help those people. So from a personal and medical perspective, that's very rewarding. From an intellectual perspective, all the immunology is really, really interesting as well. So that's a win-win, really. Yep.
We've got a couple of questions from the audience, which we might go to now. One is from Priscilla, and she's asking, we might stick with you, John. She's saying, I'd be interested to hear the reasons for using one particular protocol rather than a different protocol to do with the safety of one protocol versus another. So I might just get you to, without getting too technical, address that question that Priscilla's asking.
So what Priscilla is asking is really about the type of chemotherapy that we use before we give the stem cells back. And what we've been using is one called BEAM, which we used in lymphoma. So it's something that we're used to. So we've used it in blood cancers before. So I suppose nowadays people around the world are using another regimen which is based on a chemotherapy drug called cyclophosphamide. We plan early next year to start a new protocol using that. And so we will be transitioning to that. What we don't know is, out of those two regimens, which is the best. And best in terms of results for the patients, but also in terms of safety. So our longer term goal, and one of the things Jennifer and I and the team at Haematology and Neurology at St Vincent's would be like to, is compare those two regimens over time. What are the differences on the immune system? How do the patients tolerate it? Fertility, side effects, those sort of things. So that's one of our longer term goals. So she's right that we do use that regimen, but we are switching because most people around the world use the other regimen, but we don't actually know which is better.
Right. So again, that's a question that is probably still a way off, but that hopefully the research at St Vincent's might be able to uncover which one's the best.
Correct. Yep.
Interesting. Okay, we've sort of touched on this a little bit. John, we'll stick with you for this question. Kathleen's asking, can anybody receive stem cell therapy, or anybody with MS receive stem cell therapy, or do they need to be severely affected to do so? And I think what she's getting at there is people's level of function. You know, what's the level of function that you still need to be at before you would still qualify to be in a trial like that you run?
I think, as Jennifer mentioned before, it's more about the activity of the disease. So what we mean by the activity is the immune system continuing to attack the nerves in the brain and the spinal cord despite having treatments? So if those treatments are not working, that would suggest that, you know, the number of options for the patients is decreasing, so therefore stem cell transplant could be more justified. So people could still have relatively minor disability but have failed multiple treatment options. And what we want to see is those sort of patients with that relapsing or remitting form relatively early in their disease who have got that active disease despite having failed other treatments. So they're the sort of people that we think will benefit the most and it's most justified in.
So just further on that, has it been tried in other types of patients who fit outside that category of what you just mentioned? And has the success been less in those patients? Is that why those patients that you've mentioned are the best cohort? Is that because they're the most likely to have success?
Yeah, so I think if you're more disabled and your disease has been going longer, it's possible that the inflammation is less and therefore the treatment is less likely to work. So more progressive disease tends not to respond as well.
Does that also make a difference so that people are diagnosed relatively quickly? Because I would imagine I know maybe not so much with MS, but other conditions, it can take a long time for people to get a diagnosis, and that could then affect where they're at in their disease process. So is that also a factor as well, that it's important to get diagnosed early so that then you can see if you do qualify or is it appropriate to have a treatment like this?
I might hand that to the neurologist on the panel.
All right. So let's ask you: is that the case as well, that it's important for patients to make sure they get a diagnosis in a reasonable time so that they could potentially, you know, trial some treatments and then see whether they work, and if they don't, to go down this track of the stem cell therapy?
Yeah, exactly. So time to diagnosis, and then also appropriate or early treatment with other immune therapies. And then if patients are clearly not responding, and that might be new clinical relapse, so new symptoms or new MRI lesions, that signifies that therapy that they're on isn't holding their MS or controlling their MS, and therefore that they would benefit from stem cell transplantation. Yeah.
And just on that issue of diagnosis, is it a long period generally that people take to get diagnosed, or is it because some of the symptoms, like say, for example, that Justine mentioned, might have be sort of red flags for doctors to say that it may be MS?
Yeah, I think it's really variable. I would say in the bulk of patients, it's a relatively straightforward process. So the symptoms combined with, the patient's age. So, a young female with new visual loss would probably raise alarm bells for a lot of GPs and a lot of emergency doctors and neurologists that, this is MS. We've got good availability nowadays in Australia to MRI scans, and that will, show MS lesions in most patients who have that as their diagnosis. And so in most patients, it's fairly straightforward, but certainly if, your symptoms are a little bit atypical, if you're slightly older or alternately much younger, it may not be on the radar of clinicians as much. So we still do, unfortunately see people who have probably missed the boat with diagnosis and treatment, but that is becoming rarer and rarer.
Oh, that's good to hear. So we might just stick with you, Jennifer. We've had a question from Mike about risk, and he wanted to know what's the risk profile for stem cell therapy in the medium to longer term? Do we know, say, 5 years or even 10 years after a treatment, either with the patients that have been done in Australia or other places around the world that might be doing a similar type of stem cell under a clinical trial setting? Do we know what the risks are?
Yeah, so I guess the big things that we speak to patients about is the risk of infection, which is obviously greatest early on, but your immune system is probably a little bit abnormal or under-functioning for about 2 years following the transplantation. But the bigger two are the effect on fertility, which, as we mentioned, is really important because of the patients that we're treating, as well as the risk of what we term secondary malignancies, or malignancies that happen, or cancers that happen because of the chemotherapy that we use as part of treatment. It's very difficult to put a number on what that risk is because there are so many other factors that play into what an individual's risk of developing cancer is in the future. But essentially, we know that some of these chemotherapies do cause damage to cells that may put people at risk of developing both blood and organ cancers in the future. So we don't think that's a significant risk, but it's certainly something we counsel our patients on.
And does that mean that the patients who have this need to undergo additional screening to see if they're developing any of those problems down the track?
Our advice at the moment is that they just need to be sort of adherent to what the community standard, recommended screening is for age and sex. So nothing in addition, but I suppose just being vigilant with all of those routine checks.
And if you're as good as a patient as Justine, I'm sure that she's way across all that. We've still got a few more questions from the audience, so we might just stick with Jennifer for the moment. And this is a question from Nadia saying, is it possible for the treatment to work, but later have the immune system attack the body again a few years later?
Yeah.
In other words, is it permanent? Is the improvement permanent, or can it be, can it somehow, be reversed and the immune system go on and the attack again?
Yeah, so as we sort of touched on, in the vast majority of patients, HSCT seems to put MS into remission. We don't have good data to say how long that remission lasts, but certainly if we're looking at most of the trials around the world, following up patients to 4, 5, 6 years, about 90% of patients remain in remission. In those patients who do have either new relapses or new MRI lesions, most patients' MS, if it were to returns in a slightly less aggressive form. And so whilst there are certainly some patients that need to go back onto immune therapy, most of those patients seem to have a good response to subsequent immune therapy if they do need it. So it's rare, but it can happen.
And I might just ask John, just on that question again, in terms of the patients that you've seen and done this treatment as part of your clinical trials, have you had any cases like that, or for the majority of patients, what sort of outcomes have they had in terms of whether they're in remission or having issues down the track?
Yeah, look, I think as Jennifer said, we're seeing the occasional people where the multiple sclerosis will come back, but it's often less severe, and I think that's also seen in other autoimmune conditions. Mm-hmm. And what we do say to patients is that we don't know how long your remissions will last, because the studies just haven't done that, that long-term follow-up. So I think, I think for most patients, if they can get that 3-4 years, they're happy, and then we just keep following them each year after that. But I think we're not seeing the immune system make terrible mistakes again, and they're very disabled, particularly in the relapsing remitting group. So
just on that, so John, like with your patients or the people who have the treatment with you, how often do you need to see them, or will you follow them up? Is it once a year, or what sort of involvement do they have after they've had the treatment?
Yeah, so we see them weekly for several weeks after they leave hospital, and then we see them at 3, 6 and 12 months after the stem cell transplant with MRI scans, and then we see them yearly with MRI scans out to 10 years. So we really want to try and capture that data right out to 10 years so that we can tell patients in the future this is what we know is happening at 10 years, which we don't quite have that data yet.
So we might just ask Justine a few more questions, if that's okay. So tell us a little bit about your life now and what you're able to do now that you weren't able to do before you had. Just tell us about your life and how it's improved.
Yeah, absolutely. Look, I guess I did say it's not a miracle cure. It has definitely stopped the MS. It's been almost 4 years since my transplant, and I haven't had any episodes, or relapses. I haven't had any relapses. Obviously, the MS was quite aggressive, so it did cause quite a bit of damage. So I do get a lot of fatigue, which is probably the main thing that does slow me down. And if I'm not feeling too great, that can affect my speech, and also other things like my sensory, so my senses, so feeling and walking as well. So I'm obviously not back to how I was before I had MS, but it definitely did stop the MS, and in a way did sort of rewind it a little bit, I would say, or quite a lot, because I was barely able to do anything before. But with the right treatment and the right doctors looking after me, and the rehab, and lots of OT, speech therapy, and all the other things that I do, I haven't been able to return to work, which is something I always wanted to do, but I have accepted my special new life now, where I do focus on making sure that I stay well, because I do think I'm very lucky. And as you're asking me this question, you can see that I'm slowly starting to get a little bit more tired as it's going. So the fatigue does get to me a little bit, but I do focus most of my energy on just staying well, because I feel very lucky to have had this opportunity. Without it, I'm pretty sure that, as my doctor had said at the time, that if it doesn't happen soon, I might end up a vegetable in a few months' time. So
It's not.
it wasn't. I don't know. But look, it's my life is wonderful. I am so grateful every single day to be able to speak which I think I mentioned before. And, you know, I can't obviously do a lot of the things that I used to do, but I'm still slowly chipping away. And, you know, I'm hoping that sooner or later I'll be able to walk my dog by myself and get on a bike again one day. But I've definitely seen the improvement. It's a slow progress, but I'm getting there. Slowly but surely, I'll do it. We'll have to revisit this in a couple of years' time and see how I'm going.
You're a great example, I think, though, of showing, you know, the effort you're putting in, and that, you know, the recovery is something that you sound like you're working at every day, and that sounds like it's making such a huge difference to you and keeping you well. So
Yes.
I might just ask John, so is that important as well? I mean, it's clear that this stem cell treatment is not a magic, you know, you have it and you're back to normal the next day. How important is it that patients who might be thinking of having it or able to have it have that understanding that it is something that they're going to need to do therapy and work out afterwards, not just have the procedure and they'll be back to square one?
Well, I think it is really important. I think Justine's a good example of that. I think what we try and do is try and stop that immune attack, but unfortunately there's already been some damage that's been done. And so helping people slowly come back to normal, rehabilitation is totally imperative in that. And we actually hope with the MSRA funding over the next 5 years to look into that side of rehabilitation, and we're linking in with our colleagues at Sacred Heart to do that. And we're very grateful to MSRA for helping us launch that part of the new study. We will be looking specifically at what rehabilitation can add to the recovery of patients. And I think if we have a structured way of doing that, we might find that we can get people back you know, to their as close as possible to their pre-morbid function.
And do you think that having that rehabilitation as sort of part of it is really important for patients to realise as well, that is a big part of the process, that it's not just that, you know, you get over the procedure and then you'll be fine, but it's that you need to, like Justine, really work at it to regain as much function as possible?
Yeah, I think that's really important because it gives patients a part of, they feel like they're part of the process. You know, there's something that they can do and they can take control of, and that's really important because it's such a difficult condition when you don't have control. But once we've stopped the immune attack, you know, the rehab is something that they can be part of and be a part of controlling that process. Yeah.
So we have got another question from the audience from Jessica, and she's asking, and we might just stick with John, but we can ask the panel as well. Do you see stem cell therapy as a main treatment in the future with refinements down the track, or that even it could potentially be, even though we don't like to use the word cure, but it could potentially lead to something like that down the track, particularly you know, now that there's so much great investment in this as well, that we're seeing sort of, you know, research money put towards it. What do you think the future holds, John? I
think it'll be part of the treatment, you know, options for patients with multiple sclerosis. I'm not sure it would be for every patient because multiple sclerosis is a very variable disease. Some people have just problems with their vision, have some cortisone or other treatments, and then it settles down for some years. But I think it will be a really important component of treatment for those people that have the more severe forms of multiple sclerosis, and that it's nice to have that option for those patients. And so I think it'll be part of the treatment algorithm for multiple sclerosis, and I think these randomised studies will help us really refine which patients are going to benefit from it.
And Jennifer, what about, I might just ask you the same sort of question. Do you think it's going to be, how important do you think this work will be in the future for patients with MS?
Yeah, so I think, you know, as John alluded to, it's a very variable condition. So certainly the risks associated with the way we use HSCT at the moment would mean that it would not be required for all patients. I think in the near future, following the randomised control trials that are happening internationally, it would be, we expect that HSCT will come on par or as an alternate option for patients when they're escalating from, say, low or moderate efficacy or intensity treatments to those higher, you know, band of therapies. And then I suppose we're hoping that in the longer term, we can learn enough about how this treatment works to reset the immune system that we can adapt, the positive aspects of this treatment and, develop treatments that don't carry the same toxicities. And in that case, what we've learned from HSCT may be applicable to more patients or all patients with MS.
Fantastic, and it just shows how important the research is that you're doing, and how wonderful the research has been up to this point to get the benefits of patients like Justine and others, and hopefully that will continue with the great work that you're doing. So we've only got a couple more minutes left. So before we wrap up, I just wanted to ask each of the panel just for the last final thoughts. Maybe we stay with you, Jennifer, just for your final wrap-up thoughts, what you'd like the audience to take away from their understanding of this condition and this treatment, the final thoughts you have?
Yeah, so I suppose we've seen to date really outstanding, clinical outcomes in patients with active or relapsing MS. I'm very grateful, as we mentioned, to MSRA for supporting this research, and so hopefully we can continue to offer this treatment to patients who need it within Australia. And this has been a very satisfying or passionate field of research where you've got that personal connection with your patients, and then you're looking at their own blood samples in the laboratory the next day. And so I really hope that we can progress this research in the future to refine therapies.
Okay, great. And John, just the last few thoughts from you. What would you like the audience to take away from this work and all the work you've been doing over all these years in this area?
I suppose stem cell transplant for autoimmune conditions and multiple sclerosis is a really exciting field, and we're really grateful at St Vincent's to be able to be part of that. And I think it's, as Jennifer says, it's very personally rewarding, but it's really interesting for us. So it's as I said before, it's a win-win for us. And I think for the patients, I think they need to know that we're trying to work to make it safer. We're trying to work out how it works and to be patient with us and over that time. But I think the data's coming through, and with MSRA over the next 5 years, we think we'll see a lot more changes in how the treatment's done, and hopefully make it even more effective.
Okay, excellent. Now, Justine, just before we wrap up, last word from you.
Yes, absolutely. Well, I just want to say how grateful I am, and my angel, Dr. Moore, for giving me this opportunity. Dr. Massey, all my doctors, and St Vincent's Hospital. I'm a great advocate for this treatment. It's really given me a second chance, and I'm really hoping that it gets the acknowledgement and the funding that it deserves to give, honestly, more people that have been in my position and situation an opportunity to have a life again. So thank you to everyone, and I wake up lucky I feel lucky every single day. So hopefully there will be more people like me in the future.
Well, we hope so too, and we really thank you so much for sharing your story. It makes such a difference for us to hear the experiences of patients like you. And thank you, John, and thank you, Jennifer, and thank you, the audience, for watching. And please continue to support the great work that St Vincent's does and this amazing research. And thank you for watching, and we'll see you next time. Thank you.